Okay, hello everyone. Good afternoon. I am so thrilled to see you all. I hope day two of your YSC Summit has been off to a great start. And for those just joining us, welcome. I am Shamaya Bird. I will be your moderator for this session. I'm very excited for our guest speaker this session. And just a few small housekeeping rules, Zoom housekeeping rooms. I want to remind everyone to please keep yourself on mute. As our speaker is speaking, we will have a short Q&A at the end that will make time for folks to ask questions, but also feel free to put your questions in the chat as our guest speaker is going through her presentation. I am connected with YSC. I am a co-lead for the face-to-face South Suburban chapter for the Cancer Support Center. So that's my connection to YSC. Feel free to talk to each other in the chat as well. Let's all be open and network. Also, the website for YSC is youngsurvival.org for you to go on and connect to further sessions. We will also have the recordings available for up to 30 days or about 30 days after the final session tomorrow. So without further ado, I am going to introduce our guest speaker. And today, everyone, we have with us Dr. Sneha Phadke. Dr. Sneha Phadke is a clinical assistant professor and breast medical oncologist at the University of Iowa Holden Comprehensive Cancer Center. After completing medical school and residency in Kansas City, she went on to pursue a fellowship in hematology and medical oncology at the University of Iowa, where she remained on as faculty. Her research interests include optimizing supportive care in breast cancer therapy, new therapy options for triple-negative breast cancer, and public health. In addition to seeing patients in clinic and in the hospital, she enjoys teaching trainees from medical students to residents and fellows, and has a special interest in physician wellness and burnout prevention. So without further ado, we're going to introduce Dr. Sneha Phadke. Welcome, Dr. Phadke, and I'm going to pass it on to you.
Right. Well, thank you so much for inviting me to be here today and for coming to this talk this afternoon. I hope your summit has been going well. So I am going to go ahead and share my screen here. So as Shamaya said, I'm a breast medical oncologist at the University of Iowa. And my topic today is on cancer and therapy-related cognitive impairment, better known as Chemobrain. These are my disclosures. I don't think any of them are relevant to today's topic. So this is the outline of my presentation. So I'm going to start with some background on breast cancer and on neurologic side effects of cancer therapy, talk about clinical presentations of Chemobrain and some case studies, go into the scope of the problem, what we know from past research and also current and ongoing research, and possible treatment options. So breast cancer patients generally have an excellent survival rate compared to other types of cancer. So that's great, with about 90% of patients surviving without recurrence at 5 years from diagnosis. So with survival outcomes improving, it's really important to then optimize survivorship care. And a big part of that is mitigating some of the long-term side effects of cancer therapy. So many of you might be familiar with a type of neurologic side effect called peripheral neuropathy. It's common, fairly common after some types of chemotherapy. We don't have a great way to prevent it. More recently, we have some frozen gloves and stockings or soaking your hands and feet in ice buckets that can help reduce that risk. But if a patient gets peripheral neuropathy, it's really mainly symptomatic relief. But there has been a lot of research and attention recently given to this particular neurologic side effect. There's been less research and attention given to the cognitive issues that patients have after cancer treatment, although this is a symptom that patients and historically women with breast cancer often feel they have after chemotherapy. Until the last 10 to 15 years, maybe 20 years, most of these complaints were really largely dismissed by the medical community, perhaps because there was no way to really diagnose it. We didn't really have a way to treat it. And I think also that, this was before I was practicing, but 15 or 20 years ago, there was such a big focus on improving survival rates, which we still are focused on that. But I think with survival rates improving so much, more attention is now being given to quality of life. So these are some of the common clinical presentations, things that I see in my own clinic of patients coming and telling me, I feel like I'm forgetting things. I'll walk into a room and I don't remember why I went in there, or I don't know where I put my keys. Difficulty concentrating on a task or a conversation, they might lose their train of thought. Difficulty with complex tasks, such as multi-step processes and visuospatial tasks. So things that where you have to, follow some sort of step-by-step process can be more difficult. Very commonly, I hear people say they have word finding difficulties, and multitasking is a big one. So, especially for women who are patients, not just women, but any patient who's taking care of, multiple people in their lives, children, parents, working outside the home, just lots of things that we do in life, and we're used to being able to do all of them. And then I think it becomes sometimes more difficult after taking cancer therapy. So these are 4 patients that are not real patients on their own for privacy reasons, but I sort of took several patients that I had in my own clinic and tried to create patient case studies that we could talk about that sort of represent what I have seen. So the first case is a 35-year-old premenopausal woman who took post-operative chemotherapy followed by tamoxifen. A few months later, she feels she's unable to think as quickly, cannot perform work tasks as quickly, and feels that her colleagues are judging or pitying her, which causes anxiety. Next, we have a 37-year-old premenopausal woman who took chemotherapy, followed by medication to suppress her ovary estrogen production, and took an aromatase inhibitor with that. She has trouble sleeping and has hot flashes, which compound her concerns regarding her ability to process information and remember things. A 41-year-old woman who works part-time and has young children and consistently feels she has word-finding difficulty, often gets anxious in work and social situations because she may lose her train of thought. And a 46-year-old woman with metastatic breast cancer who has received several chemotherapy agents and has had radiation to her brain. She's had symptoms of gradual cognitive decline and trouble with memory, which became more apparent after radiation. So we'll talk about several of these symptoms as we go through the presentation today. So next, I want to go into some of the existing research in this area and discuss the scope and the severity of the problem. So this first study looked at cognition in breast cancer survivors after they completed chemotherapy and compared them with age-matched controls. So patients with breast cancer from community oncology clinics and age-matched non-cancer controls completed this questionnaire called the Functional Assessment of Cancer Therapy Cognitive Function, also known as FACT-COG. And they took that at pre-chemotherapy and post-chemotherapy time points, as well as 6-month follow-up and just a 6-month follow-up after finishing chemo. So this study enrolled 581 patients with breast cancer and 364 controls. And what they found was that patients with breast cancer reported significantly greater cognitive difficulties on the FACT-COG questionnaire from pre-chemo to post-chemo compared with control patients, as well as pre-chemotherapy all the way up until that 6-month follow-up. Increased baseline anxiety, depression, and decreased cognitive reserve, meaning sort of the how much brain function do you have that can sort of compensate, I guess, if you do have some decline. These things were significantly associated with lower total FACT-COG scores. The treatment regimen, hormone or radiation therapy, was not significantly associated with those scores in patients from the post-chemo time point, so right after they finished chemo to 6 months later. I also think it's important to note that the study found that from the time of diagnosis until after completing chemotherapy, 45%, so almost half of patients, reported a significant decline in cognitive function compared with 10% of the non-cancer controls in that same time period. And from before chemo to 6 months after completing chemo, 36.5% of patients reported a decline in cognitive function compared with just about 14% of the non-cancer controls. So the number of breast cancer patients that had these subjective cognitive issues went down as time went on, but was still significantly higher than patients who had not had cancer. So the next study I wanted to go over was called TAILOR-X. So TAILOR-X was a trial that basically was studying this test called an Oncotype test, and it put women randomly in 2 different groups: chemotherapy and endocrine therapy, also called anti-estrogen therapy, or just anti-estrogen or endocrine therapy alone. So this study was done on cognitive impairment, was done as part of what's called patient-related outcomes, and it was a sub-study of the bigger study. So women were given the FACT-COG questionnaire at baseline, 3, 12, 24, and 36 months, so looking about 3 years out from treatment. And ultimately, there were about 454 women who were evaluable for this endpoint of cognitive impairment, meaning that that was the number of patients that had data. They had finished their surveys. So you can see in this group, it wasn't all very young women. There were some women, about a third under the age of 50. They were on different types of endocrine therapy. Some were on aromatase inhibitors, some on tamoxifen. A very small number had their ovarian function suppressed, and some patients did change their anti-estrogen therapy during the study. So what they found was that women that were randomly assigned to getting both chemo and endocrine therapy reported a significantly greater cognitive impairment from baseline to 3 months and then baseline to 6 months compared to women who were randomly assigned only to the endocrine therapy portion. So you can see that in all the patients here that there was a change, but it was greater in the patients in this red group, which was the chemo and endocrine therapy arm. A higher proportion of women that were randomly assigned to chemo and endocrine therapy had a clinically meaningful change in their cognitive impairment from baseline to 3 months. So this is this first little drop here compared with endocrine therapy alone. But even the endocrine therapy group that did not take chemotherapy had some decrement in their cognitive impairment. And actually, it slowly decreased over time. And at some points almost converged in terms of, when we're talking about the statistics, actually those numbers sort of were not really significantly different. And as a whole, these cohorts never really got back to their pre-chemotherapy baseline at 36 months out. It did stabilize, but they didn't get back to their baseline. The same magnitude of cognitive changes were seen regardless of age, but there were differences at different time points. So in this post-menopausal group, you can see there was a significant difference between endocrine therapy alone and chemotherapy. So this is this group here. At both 3 months and 6 months, and sort of then continued out after that. In the premenopausal group, you can see that there's a much larger difference here between the groups at 3 months, and then they converge actually. And so endocrine therapy seems to have a similar effect on cognition to chemotherapy, at least in this younger group. So the next study I wanted to go over was actually in patients with colorectal cancer. So this is a study that looked at patients who had changes in cognitive function, but did not actually, some of them had not actually gotten chemotherapy. So the study enrolled both patients with colorectal cancer and non-cancer controls. They got a cognitive assessment before chemotherapy and then again afterward. 289 patients had localized colorectal cancer, 73 had metastatic or recurrent disease, and there were 72 non-cancer controls. Cognitive impairment was more frequent in those with localized colorectal cancer than the non-cancer controls at baseline. So you can see 43 versus 15%. And at 12 months after chemo, 46 versus 13%. And it didn't seem like chemotherapy made a difference because the number here didn't change much, but it is much higher than the non-cancer controls. So when you looked at that, when you looked at patients who had received chemotherapy and compared them to patients who did not, more people who got chemotherapy had cognitive impairment at 6 months, although there was not a what we call statistically significant difference at 12 months. So that number went down a little bit, suggesting, I think, that over time, symptoms of chemobrain typically get better. The cognitive decline or cognitive impairment was similar between patients with localized versus metastatic colorectal cancer. So the figure to the right here shows the changes in each group by time period. So baseline 6 months, 12 months, and 24 months. And each row is a different type of cognitive test. So this is the scores or the impairment, I guess, depending on these 3 different tests. And you can see that the percent impaired changes in each group over time, but even looking across these tests and across the type of colorectal cancer, there's a marked difference between these 3 groups and the healthy controls. So the last study I wanted to review was an older study from 2010 that assessed cognitive function in a group of 71 women with breast cancer prior to chemotherapy, a week after completing the last cycle of chemotherapy, which was called AC, 1 week and then 6 months after completion of all chemotherapy. Interestingly, cognitive impairment was found in 23% of women prior to chemotherapy. And when they did some statistical modeling, they found that significant decreases after receiving chemotherapy, but that was followed by improvement about 6 months after the completion of chemotherapy in these domains of visual, spatial skill, attention, memory, and motor function. These other types of cognitive domains did not change over time. So the implication here is that perhaps a breast cancer diagnosis itself may be associated with cognitive impairment in terms of some of the psychological distress that comes with a new cancer diagnosis, and maybe that causes some temporary cognitive impairment. The other thing I think is important to note is that while chemotherapy seemed to have a negative effect on cognitive function, the impairment seemed to be more of an acute side effect rather than a chronic side effect, at least in this study, meaning that the symptoms tended to get better, a little better over time. So just a few thoughts as we wrap up this section of the talk. Maybe we should be calling this cancer-related cognitive impairment because some patients who did not take chemotherapy had evidence of cognitive impairment, and some patients who took cancer therapy but not chemotherapy, like those in the Taylor X trial who just took endocrine therapy, did have some evidence, at least subjectively, of cognitive decline. So maybe the term chemobrain is really not broad enough to include all types of cancer-related cognitive impairments. Whatever we call it, it seems like in most of the literature, not all, but most, that it does stabilize or improve over time, both subjectively described from patients and objectively as we measure it in different ways. It seems to affect multiple domains of cognitive function, but doesn't seem to be associated with any one type of cancer, a certain stage of cancer, or any one type of chemotherapy. And I think that, trying to figure out if one type of chemotherapy over another is more likely to cause chemobrain is hard because so many patients get combination chemotherapy. So that's one piece that does make things more difficult in terms of the research. So next I'm going to talk about some of the previous research tools that we have used to look at diagnosis and mechanisms of chemobrain. So in the studies that are going on right now, common ways to measure cognitive functioning include neuropsychological or neurocognitive testing. That involves various memory tests, tests of decision-making, executive function, and attention. The FACT-COG, as we've talked about, is frequently included. It's a questionnaire that looks at many different aspects of cognition and quality of life in patients who had cancer. Brain imaging is very commonly used as a research tool. And interventions that are being investigated are things like neurostimulants, so methylphenidate, also known as Ritalin or modafinil, and anticholinergics such as donepezil, which is a treatment for Alzheimer's dementia. Most researchers also usually ask patients about symptoms of anxiety and depression because those can certainly contribute to cognitive function. And most research in chemobrain has been done in breast cancer patients. And these are the 4 reasons why that is. First of all, breast cancer is common. Breast cancer patients often have limited comorbidities, meaning that they're in generally good health. Breast cancer survival rates allow for longitudinal assessment, meaning we can follow patients over time. And there are a substantial proportion of breast cancer patients who do not get chemotherapy and can act as a control group. So if you look online, you'll see several clinical trials that are going on right now, investigating different aspects of Chemobrain. And I took a sampling here and divided them into those that are looking at how to diagnose Chemobrain, and then those that are evaluating treatments for Chemobrain. And we'll go into a few more of these in the next slides. So before I go on and talk about those things, I did want to just share some of the possible ways in which chemotherapy or cancer therapy could cause brain injury or CNS injury, which is central nervous system. So this slide does get into the weeds a little bit in terms of detailed science terms, but I wanted to at least touch on some of these things because I do think that they're important. So one of the hypotheses is that chemotherapy inhibits hippocampal neurogenesis. The hippocampus is a structure in the brain that is important in learning and memory. And neurogenesis is making brain cells, basically. So inhibiting making brain cells that are important for memory and learning is a possible mechanism of how chemotherapy may affect the brain. Oxidative damage, or basically direct damage to brain cells, including the white matter of the brain, and also decreased hypothalamic pituitary adrenal axis activity. So this is a hormonal axis in the body. One very recent paper, a very interesting paper, investigated the theory that the damage may be inflammatory and results from disruption of intestinal bacteria and the development of basically chemicals that can cause inflammation. There have been mouse models looking at whether chemotherapy can actually cross into the brain. We really generally don't think it can. There's something called the blood-brain barrier, which is very important and protects things from crossing that are in the rest of the body. And that's really important as a protective measure for the brain. And so we don't think that chemotherapy can actually get into the brain in any significant concentration, but it may be that small amounts of chemotherapy can cross the blood-brain barrier, and those could have toxic effects. Another older but really interesting study looked at the effects of chemotherapy on general aging and showed that breast cancer patients who took chemotherapy showed an increase in this gene called P16-INK4A. So this is a marker of aging cells, and it's equivalent to the increase that's observed over about 15 years of chronological aging. So this is very, it was a small study, and it's really interesting, and I think gives us a lot of potential insight into a lot of the side effects of chemotherapy. And so I think that maybe, at least in some patients, especially patients who maybe are a little older to begin with, that possibly Chemobrain is actually accelerating what would have normally taken place, some of the cognitive effects just of normal aging. So I'm a clinical investigator or researcher on 2 clinical trials that we currently have open at the University of Iowa that are looking at accurate diagnosis of Chemobrain and also treatment. So the first is this study. It's called Brain-Based Biomarker Tools to Assess Cognitive Deficits Associated with Chemotherapy. And the aim of this study is really to try and find or to clarify diagnosis of Chemobrain, looking for some sort of diagnostic criteria, because really we don't have that right now. Any diagnosis of Chemobrain is somewhat subjective on the part of the physician or the patient. So that's really the aim of this study. We're looking specifically at executive or higher order cognitive function, meaning planning, decision making, things that we do normally in our daily lives as adults. We're using a special MRI technique called magnetic resonance spectroscopy with a very clear type of high resolution MRI imaging called 7T. And we're looking at biomarkers related to cognitive deficits. So we're trying to track actually these neurochemicals that may, the concentrations of them may change over time, before and after chemotherapy. So this is basically what the study looks like. So patients who have early stage breast cancer, we're also including patients who have a certain type of lymphoma called diffuse large B-cell lymphoma. If they're planned to get chemotherapy, they can potentially enroll on the study. And before they start chemo, they undergo this high resolution MRI and neuropsychological testing as sort of an objective measure of their baseline function. They then take their chemotherapy, and while they're doing that, we give them online assessments of pain, mood, and sleep, and some other symptoms to see if those may contribute to someone's subjective feeling of cognitive decline. And then after chemotherapy, we repeat the MRI and the neuropsychological testing. So I won't go through all the inclusion and exclusion criteria here, but you can see that basically if you have an early stage breast cancer diagnosis, you can be eligible for this study. So the other study is looking at an intervention called transcranial magnetic stimulation. So, or TMS is what I'll call it for short. So TMS is a non-invasive procedure that uses magnetic fields to stimulate nerve cells in the brain and improve symptoms of depression. So right now it's approved for refractory depression and obsessive compulsive disorder. It has not been really used to look at symptoms of Chemobrain before. So we're testing the safety and efficacy of TMS for any adult patient who took chemotherapy as an adult, and then also looking at if there's any changes in their FACT-COG questionnaire. So they're also getting an MRI, and they're also getting the neuropsychological testing, kind of pre and post intervention. So currently options are limited for prevention and treatment, and there's really not enough evidence to say that any one of these works over another, but there actually is some reasonable data that we'll go through here on these different types of treatment and prevention options. So exercise, we'll talk about that. There are some studies looking at exercise, meditation, cognitive rehabilitation, basically brain retraining or coping mechanisms. Psychotherapy and group therapy, especially peer support, has been shown to be helpful. Neurocognitive testing can be helpful just to understand what the deficits are so that you can sort of figure out specific coping mechanisms. And then treatment of any underlying conditions that may be exacerbating the issue. This is crucial to treat anxiety, depression, sleep disturbance, pain. Those things can certainly contribute to symptoms of Chemobrain. And we'll talk a little bit about probiotics. There was a recent study that looked at taking probiotics as a prevention measure. So this study I was very excited to read about. It's a really interesting study that looked at taking a probiotic pill as a preventive measure for Chemobrain. So this is a study that they randomized people, meaning they randomly assigned people to either take a placebo or a probiotic. And you can see that the probiotic they used contained these three types of probiotics. They assessed cognition, anxiety, and depression. And also took some fecal and plasma biomarkers to actually see if they were doing what they were intending to do. And what they found was that the probiotic supplement significantly decreased the incidence of chemo-related cognitive impairment, improved overall cognitive function, and it did change the gut composition of the microbes in the gut. So it's promising for sure. It's a very small study, only 159 patients. But I think the good thing about probiotics is that there's almost no side effects for most people. And so this is something that I think can probably be done, and really we don't have to worry too much about the harm. So exercise is another intervention for which we have a fair amount of data showing it's important for multiple areas in survivorship care. So one large study enrolled 580 patients with stage 1 to 3 breast cancer and evaluated their physical activity levels and several measures of cognitive functioning at pre-chemotherapy and post-chemotherapy time points. So patients who met the recommended physical activity guidelines, which was a third of their population, had better cognitive scores on the FACT-COG and other measures. And recommended physical activity is about 150 minutes a week of cardiovascular exercise. So what they found is that moderate to vigorous physical activity at one time point predicted for a better cognitive trajectory, and adhering to physical activity guidelines throughout chemotherapy was associated with an improved self-reported cognition. So I think this is great news because it's an intervention that patients can take into their own hands. It's not something, it's not a pill that needs to be prescribed. I have many patients tell me that they don't want to take more pills. So, and it's good for many different aspects of health. So I think this was a really important piece of research. I wanted to touch on this interesting study. It was presented at one of our breast cancer conferences last year called Pathways to Wellness, and it investigated a mindfulness intervention for younger breast cancer survivors. So this was a randomized trial over many institutions, 3 arms. It tested the efficacy of 2 behavioral interventions for younger breast cancer survivors. So these were the 3 arms: mindfulness awareness practice, where they were basically kind of taught how to practice mindfulness; survivorship education, kind of general education about survivorship; and there was also a waitlist control arm, which these people who got randomly put into this group after 9 months could then choose to be in either one of the other 2 groups. So assessments were done at pre-intervention and post-intervention, 3 months and then 6 months after completing the intervention. So what they found was that mindfulness awareness practice and survivorship education decreased depression symptoms from pre-intervention to post-intervention related to the waitlist controls, and that at 6-month follow-up, these changes persisted for those who were in the mindfulness arm. The survivorship education arm, however, those effects seem to wane over time. Mindfulness practice also had beneficial effects on fatigue, insomnia, and vasomotor symptoms or hot flashes, and those benefits also persisted at 6 months. So as someone who personally has benefited a lot from mindfulness meditation, I would love for all cancer centers and hospitals to be able to start a program like this. I think this could be so beneficial for a lot of the anxiety and the fear of recurrence that's so common after a cancer diagnosis. It does take funding and resources, but I think this would be such an important part of survivorship care. A few small studies have also looked at the medication donepezil in survivors of childhood brain tumors in adults with low-grade brain tumors. And again, this is an Alzheimer's dementia medication that's approved for that indication. And it did improve some of the cognitive domains, executive function, attention, memory, and concentration. This is these are small studies, and there are 2 or 3 small studies. Very limited population in terms of patients who have brain tumors, but I think also potentially very promising. So that's all I have. Thank you so much for your attention, and I'm happy to now take any questions.
Thank you, Dr. Fadke. That was such a great, informative presentation. We have quite a few questions. I'm going to just list it in order here, you all, but if I'm not asking the question right, or if you want to bring yourselves off mute for any follow-up, please feel free to do so. So the first question we have here is from Nora and Pinkoff. Please correct me if I pronounce your names wrong. But her question is regarding the neuropsychological testing. And she mentioned that she'd been waiting to access it for years and been having a problem with insurance, and was told that insurance doesn't cover it. And she mentions that she is disabled and low income. Do you have any recommendations for getting this kind of testing done?
Yeah, that's a tough one because insurance can dictate what a person is able to do. So I think I don't know where this particular person lives or what type of facility they go to, but sometimes trying to go to a university, especially if they have any research protocols there, then it would be covered. Or they might have some sort of financial assistance program. But unfortunately, I don't know of any other resources right now.
Nora, did that answer your question?
Yes, it did. Thanks. I'm in Ohio right now. I'm at the James Center for Cancer.
Okay, so you are at a university.
Yeah,
Okay.
yeah. And I'm not really sure if I'd be able to access that through them, but I'll try to look into that. Thank you.
Also, I just want to encourage everyone real quickly too. We may have similar questions, or we may have answers beyond the scope of what Dr. Fadke presented to us today. So feel free, everyone, to definitely just message each other in the chat for further communication. If we have resources as well, we want to be friendly and share our resources to everyone. The next question, Dr. Fadke, is from Ronzi. And she asked well, she just stated that she tried taking the medications but didn't see any difference. I believe that was from the psychological section as well, the neuropsychological question as well. So do you have any take or insight on that as far as the medication goes?
No, except that is unfortunately common. I think I think my main takeaway from today is that this is an area that is still well in the research phase, and that unfortunately we don't have good treatments or good preventative options. And so we're working on it. But like I said, unfortunately, I hear that a lot, that the things that are recommended just unfortunately, something didn't work for a particular patient.
Yeah. I have a quick follow-up question, then I'll go to Nora's next question, and then we have a few more questions after that. What's the difference between the I think it's the neuropsychological testing, and then the other
Neurocognitive.
Yes.
They're really the same thing. They're just called different things at different places, and that's why I included both.
Got it. Okay, our next question is, are there any preventative supplementations we can take to reduce long-term effects like magnesium or other redox or antioxidants supportive supplements? And this is in relation to stating that some stimulants can cause oxidative stress over a long time, which can also result in cognitive decline.
So there's nothing that I know of that a supplement that can definitively prevent chemobrain. I think that if you were going to take something, I think probiotics may be a good option. I would tell your doctor you're taking them and make sure that I think that's okay. But they're generally, safe, and they usually don't interact with any of the cancer therapies. And so I think that would probably be a reasonable thing to try.
And on the subject of probiotics, we have Terry that asked the question, are probiotics helpful post-treatment for permanent chemobrain?
Well, we don't know the answer to that.
Okay.
That has not been studied yet. And so I don't know. But again, I think it's a low risk thing, and people take probiotics just for the probiotic effect of, kind of regulating the gut. And so I don't think it's probably a dangerous thing to try.
That's probably in relation to, I feel like this is a very similar question asked here by Aaron. Is it recommended to take probiotic with immunotherapy? Is there any research done on that?
I don't know of any research specifically on probiotics and immunotherapy. Off the top of my head, I don't think there would be any reason to not take that, but that's not something I've necessarily looked into myself.
Got it. And then we have another question here. For the physical exercise effectiveness component.
I messed that one up. That's only half the question.
Oh, okay. Well, go ahead.
So
I'll let
see
you
more
ask
of it
your
later.
question. No, you can go ahead and ask your question.
Okay. I'll just read it from the thing. And I want to make sure we don't miss other people. For the physical exercise effectiveness component, does the exercise need to be in a specific context? Like I read a recent study that about increasing neuroplasticity that had statistical significance for specifically the difference between running and actually getting somewhere versus just using the treadmill. So is there anything that has to do with that, with the efficacy for that component?
I don't think so, but that's really interesting.
Yeah.
I didn't know that. I don't think I had not read that.
It's fairly recent.
Yeah, the research that has been done, I think, was specifically just any type of cardiovascular, moderate to vigorous cardiovascular activities. That could be, walking on a treadmill, biking, but it didn't have to be in a specific context. So that is a really interesting.
Yeah, it's fascinating.
Process.
Thank you.
Yeah, that was actually something similar that I kind of questioned about, because my oncologist recommended for me to do exercise during chemotherapy as well. However, he didn't specifically state, like in the context, what kind of exercise to be doing. And I was one of the, like, I sort of was already exercising beforehand, and chemotherapy kind of slows you down. So I think that'd be something definitely worth exploring more, like, because for those, depending on your like chemo regimen, if you're going every other week, 2 weeks, you know, every 3 weeks or so, by the time you get your strength back, it's like you're going back for chemotherapy again.
Yeah, that's a great point. I think something to maybe just consider is that some people who are, you know, vigorous exercisers before they take chemotherapy, they, you know, may feel like they need to try and keep up that level of exercise. But even just walking for 20 minutes at a moderate pace, that could be good enough, you know, so it doesn't have to be something where you're really breaking a sweat and, you know, exerting yourself. It can be something more moderate for a shorter period of time, or you can do 10 minutes 3 times a day or something. So you can break that up a little bit too. But yes, definitely that does become harder as you get more fatigued.
Yeah, good point. Good point. Okay, we're gonna take a few more questions here. We have a little bit more time, a few more minutes. This is from Emily, and Emily asks, are there any studies to join for people who are just on tamoxifen and have not done chemo?
I don't think so. Not right now. I think that'll probably come in the future. But I think one of the difficulties of doing research in this area is trying to make sure that your population is sort of similar enough to each other that you can get some good results, and then hopefully get funding for a much larger study. And so some of the, you know, we often have to have pretty strict criteria for people entering a study so that we can sort of get interpretable results. So unfortunately, I think right now it's only for patients who took chemo, but based on the data that I showed you today, I think it's really important to include patients who did not, because it's clearly there is an effect of endocrine therapy as well. I've seen it not only in the data, but in my own clinic.
Absolutely. And that study was very interesting to learn that it was done on patients, you know, without chemo as well. We have time. We have 3 minutes left, so we'll take 2 more questions. And if anyone wants to ask Dr. Fatke any further questions, again, this will be posted on the website. So I'll ask 2 more questions. Let's see. This question says, does Lupron cause fog and anxiety due to estrogen suppression? And that is from Shruti.
Yeah, in my own practice, I think I would say yes. I don't know of any data specifically on that. I do see another question right under that of soft and text. Those were the 2 trials that looked at drugs like Lupron to suppress ovaries. And so it would be super interesting if the investigators on that study had some data about the effect of ovarian suppression on cognitive impairment. Right now, I don't know of any research specifically of drugs like Lupron on cognitive impairment, but I can say that just in my own experience, I definitely feel like I have patients on those types of medicines that feel that they have symptoms of Chemobrain or cancer therapy related, you know, cognitive impairment.
Yeah, yeah. And then our last question, right before we wrap up, we have one last question that asks, how about any studies about how light therapy may affect CI?
I don't know of any studies on light therapy. That would, I mean, the intervention that we are testing now is an intervention that we use for patients with mental health issues, and light therapy is also something that's used for mental health issues like depression. And so I could see that it might be helpful. I wonder, you know, because we don't actually know why exactly patients get cognitive impairment, it's hard. I think we might end up having multiple possible treatments depending on sort of the individual cause. So if you have some level of depression that's also contributing to it, light therapy may be really effective. So no, I don't know of any research right now, but definitely an interesting thought.
Well, thank you, Dr. Fatke, again for joining our summit. Thank you, everyone, all of our participants for joining Let's Talk About Chemobrain session. And I hope you all enjoy the rest of the summit. Thank you.
Thank you so much.